At this point, we will start the mapping phase of the procedure.
It is the routine practice in our electrophysiology laboratory to obtain a pre-procedural cardiac CT scan. The CT scan is helpful for a number of reasons. One, it allows us to delineate the pulmonary venous anatomy in advance. It also is important in excluding any anatomic abnormalities that may be present in a given individual. Certainly in patients who are coming in for a repeat procedure, the CAT scan can be helpful to exclude the presence of pre-existing pulmonary venous stenosis. We use the data that we see in the cardiac CT scan in combination with the real-time intracardiac echocardiography and the pulmonary venous angiography to determine the optimal sites for ablation. Unfortunately, in this patient, for insurance reasons, the cardiac CT scan was done in an outside facility, and you can see from the scan that it is somewhat of a suboptimal recording, and certain pieces of the left atrial roof did not opacify as well as we would have liked. Nonetheless, in this PA view of the heart, you can see 4 veins: the left superior, left inferior, right superior, and right inferior veins. As we rotate the image around, one can start to appreciate the left atrial appendage in this anterior projection. At first glance, it would appear that the left-sided pulmonary veins have a common antrum. To further define that, we will clip this CT scan to take an endocardial view of this left atrium. As we start to see the clipped study here, one can see clearly that the left-sided pulmonary veins, the superior vein and the left inferior veins, quickly empty into a common antrum. And this will be important information as we delineate our ablation strategy going forward. In contrast, for the right pulmonary veins, we can see here that there are clearly 2 discrete ostia to these veins for the for the right superior and right inferior pulmonary veins. If we go back to our left-sided pulmonary veins, one can also see very nicely the ridge that separates the left atrial appendage from the common left-sided veins.
So we'll be using an irrigated thermocool catheter, and the first thing we'll do is we'll get the thermocool catheter up through our left atrial sheaths, and we will enter the left-sided pulmonary veins typically initially. That'll allow us to do a cardo image and tag the vein, and also we will perform pulmonary venous angiography. This is a D-curve thermocool catheter, 3.5 millimeter tip. For the, we really use the sheaths a lot for steering, so the catheter is a little more passive in this procedure than it might be in other procedures. The left-sided pulmonary veins are and the upper, typically around 2 o'clock or so in this image. Make sure your sheaths turn posteriorly, and while recording, we'll gently advance it into the pulmonary veins, and then we'll be able to tag and by advancing the sheaths, perform an angiogram. Okay, can we tag this? You can label this. And this will appear on our cardo image. The distal portion of the catheter is in the left lower pulmonary vein. Ready? Okay. Yeah, you can see actually very nice.
Yeah, there's a
Right?
short
So the-
common trunk.
Yep. So just for orientation, the angiographic catheter, the sheath, is pointing directly at the left lower pulmonary vein, which sits just where the esophageal probe is crossing, and the left upper pulmonary vein, looking at the LAO image, the left upper pulmonary vein is very vertically oriented and is coming straight off the roof. And there is a common trunk which stretches from about the tip of the esophageal probe to about what would be 12 o'clock on the LA image. So it's a short common trunk. And in this case, we'll probably put a lasso catheter inside the common trunk, and that'll allow us to record the pulmonary vein potentials within the common trunk, and also later move them into the individual branches to make sure they've been isolated. Sunit, how much does that measure about?
Yeah, it's looking between about 25 at least.
Yeah. And the trunk is a little bit on the short side, the common trunk, and slightly large, which often makes it a little hard to keep the lasso catheter stable, but we will put it in and we'll see how it works. It would be a case where you could put the catheters in each of the branches as well and just ablate it at the LAPV junction or antral area and made sure you isolated each of the branches. We like to look at the common trunk since that will contain pulmonary vein potentials that are distinct. And you can see there is a nice shelf of tissue in between the upper and lower portions. It's very important that you address that area as well. And that's one of the advantages of mapping the common vein, making sure you then isolate all the structures distal to it.
The individual veins appear somewhat small. There'd be some concern about stenosis.
In the individual veins?
Yeah.
Yeah. Good. That's good. So we keep a reference angio image that allows us in a two-dimensional still format to look at the targeted anatomy in relationship to X-ray imaging. So for example, we can know where the pulmonary vein orifices are relative to the spine, to the other catheters, to other anatomic landmarks, and that's just yet another tool to use in positioning the catheters carefully. Okay, that catheter, lasso catheter, looks like it's probably sitting in the common orifice, judging from our angio images. And you can see the recordings on the screen. It's not possible to determine whether those are atrial or pulmonary vein potentials, but more than likely both. And if you look at the ultrasound image, you have a very, very nice picture now of the lasso catheter sitting at the proximal segment of the common orifice, and that's perfect for our purposes, and that way we can record all the common pulmonary vein potentials, or at least those that we're making contact with. Looks like it's filling the circumference, and will allow us to position our ablation catheter proximal to that and hopefully accomplish everything we need to. And now Dr. Mittal has turned on the pacing, and presumably what we're now seeing is left atrial capture from the distal CS bipole, and more easily readable pulmonary vein potentials with a pattern of early entry at one of the bipoles on the lasso and then later activation elsewhere. There may be a couple of entry sites that we could potentially target.